Digestive Systems Lab, SPECS, of the Institute of Bioengineering of Catalonia, IPEC. She's a team leader of the neurorehabilitation area, chief scientific officer at Eodyne Systems, and associate professor at Universitat Pompeu Fabra and Universitat Oberta de Catalunya. She has a background in computational science, development of VR-based solutions for value-based healthcare, clinical validation, and a track record in neurorehabilitation. Thanks a lot, Dr. Ballester. Please go ahead.
Thank you so much. So I will share now my screen, if I manage. Let me know if you can see.
Yeah.
Yes, you see it full screen right now?
Yeah, we can see your slides, yes.
Okay, fantastic. So thanks so much. I think these are really good initiative. We are in this strange, living this strange situation with COVID, and it's the moment to make these links. Yeah. I really like that you're pushing the modeling work in stroke. So I think this is a really nice opportunity. Thanks for the invitation. So I'm going to present, if I get out of, I will try to control the time, but just let me know if I'm taking too long. And if you would want to ask any questions in the middle of the presentation, I'm happy if you don't have any issue with that. So I'm going to present a number of studies that we conducted at our lab for the last years, but we started doing this for the last 10 years. So it's a lot of time that we have been working on stroke. And at the end, I will also present a study that is not on stroke, but is on addiction. So cannabis users, but it's an example of how we are now trying to generalize the principles we are learning from stroke, the stroke case, to other conditions. So first of all, let's see what a stroke patient is. Most of our work is based or focuses on treating hemiparesis, which is weakness on the upper extremity. So this is a patient that presents hemiparesis on the left upper extremity, as you can see. The weakness at the distal level is preventing him from opening or having enough strength to open the jar. He may present also a little bit of spasticity at the distal level. You see that the fingers are flexed, right? So this is the type of behavior that we can observe after a patient had a stroke, since 80% of these patients are presenting hemiparesis on the upper extremity. And so what happens after having a stroke? So neurons are deprived from their metabolic substrate, and we observe conditions emerging, such as hemiparesis, but also aphasia, so language issues, emotional issues. We can see depression. So it's very, very diverse, the patient we find with brain injury, stroke injury. So just after the stroke, at least here in Spain, but this depends absolutely on the country we're looking at, the patient is hospitalized, and the patient goes through an inpatient phase. So in this phase, the patient is at the hospital, and he may be supervised and receiving some early treatment. Then after a few weeks here in Spain, the patient is moved to the outpatient phase, in which he may even move to another center, daycare center, for instance, in which he will follow up or she will follow up a rehabilitation program. It can be rehabilitation on motor function, but also on language production or other skills. So this time, this outpatient phase can last in between 3 to 12 months maximum in Spain. And during this period, the patient, we see that recovers function. After this period of rehab, the patient is discharged. We call it like the end of therapy. And after the discharge, something very special happens. I'm going to focus most of my presentation in what happens after the discharge. But first, let's look at this stage of recovery that happens at the first months. This stage is characterized by two phenomenon or two patterns that we can identify in the recovery. One is that the recovery seems to be proportional. So those patients that are more affected due to the stroke seem to recover more function. It's not clear which is the exact ratio of recovery. Actually, it may not be fixed for everybody, but it seems to be proportional. And it's structured too. It's structured in time. So the second rule or the second pattern we observe in recovery and how the brain repairs itself is that it will repair faster in the early days post-stroke and slower in the later days post-stroke or at the more chronic phases. Okay, so we see that recovery is proportional and structured, and there's plenty of evidence for this. We can discuss this in the end if you would like to, because it's actually a hot topic, but I think there is a lot of evidence supporting this. But what happens after the end of the therapy is that the patient is discharged and the patient does not follow any specific rehabilitation program, maybe none at all, and we see a deterioration. And this deterioration, according to literature, reaches about 80% loss in the 4 following years after the discharge. And this is what we call rehabilitation in vain. So it's a lot of recovery that the patient experienced due to effort and exposure to therapy that is lost. It's a waste of money, it's a waste of time, it's a waste of effort. And this, we believe, is a serious problem that we need to focus on with big socioeconomic impact. And further, many of these patients that experience this deterioration also will be readmitted into the hospital due to the reoccurrence of a stroke or to just the deterioration leading to other conditions. So that's why you will see that most of these studies that I'm going to present focus on how to deal with retention. We identify 3 pillars in the rehabilitation field: improvement, retention, and generalization. With generalization, I mean that whichever skills that the patients regain during training or rehab, we want them to transfer into activities that are meaningful to the patient, for instance, activities of daily living, right? Otherwise, there's no impact in the patient's quality of the life and independence. That is actually where we want to have an impact. So we identify these 3 pillars, and we also identify different principles that are somehow boosting the outcome of recovery in these 3 different domains. For instance, just to give you an example, if we give to the patient a therapy that is variable, that includes different like noise from different sources, for instance, or we may imagine that we expose the patient to dealing with objects with different physical properties, then we see in literature that there is some evidence supporting that this type of therapy will lead to skills that generalize better to other activities, right? And we only identify many principles like masked practice, practice that is structured in time, so practice that is introducing resting periods, which also promotes the retention of learning and gains. So there are many principles. What we started doing at our lab in already 2007 is we wanted to develop a system that was kind of automatizing stimulation in therapy or tasks, implementing tasks for therapy for rehabilitation that would be grounding on these principles, right? Some of the principles that I'm mentioning now, we didn't know by then, but we try to do like our research focuses on both pushing the application that implements principles and trying to discover which are those principles, right? Okay, so here you can see the system we initially developed. This is the rehabilitation gaming system. We call it RGS, and it's just comprised of like a webcam on the top in the beginning, but now we are using Kinect, Microsoft Kinect, that is a depth sensor. It's capturing the movements of the patient and is mapping them into the movements of an avatar that the patient can see in real time on the screen, right? So he's able to manipulate and interact differently with objects. You can see, for instance, that the screen is divided by a white line. It contains different design we made some decisions in the design that are trying to implement these principles I said before. And one principle, as I said, is must practice. So for instance, we don't want the patient to overcompensate by using the non-affected arm. So that's why we divided the screen into workspaces that are kind of operating independently in a way that when objects appear on the workspace that corresponds with the paretic limb, the patient has to use the paretic limb. Also, the difficulty of the game is characterized by different game parameters like the speed of the objects, the size of the objects, and this adapts automatically according to the patient's skills. But let me show you some results now. That is the most interesting part of it. So we have tested many patients with these systems. With this system, I would say thousands now, because we transferred the system to a startup, Iodine, that is distributing the system and keeps on collecting data on different patients. But here I'm showing you only data from around 270 patients that we tested in 3 hospitals from Barcelona in controlled conditions. So these patients were belonging to specific studies that we were supervising. And we measured recovery in different clinical scales. Here I'm showing the Fugl-Meyer scales. And the nice thing is that we managed to include in our sample patients that were at different stages post-stroke, at the acute and subacute stage, at the early chronic, at the late chronic. And they all were exposed to the same protocol with the same RGS-based training setup. So we analyzed this data trying to answer the question of how chronicity is influencing the patient's responsiveness to therapy. So as you may know, there is this concept of the critical window of recovery that is related to the principle I was mentioning before. Recovery is structured in time. So the earlier the patient is exposed to therapy after the stroke, the higher is the response of the patient to therapy. Some literature supports that this critical window of recovery is associated to enhanced plasticity mechanisms due to the lesion itself. And this window may last in between 3 months, 6 months. The maximum that has been mentioned in literature is 6 months. So here what we observe is that even at the early chronic stage, this early chronic stage is beyond 6 months post-stroke until 1.5 years post-stroke. The recovery or the responsiveness of the patient to therapy is significantly higher than patients at the late chronic stage. Unfortunately, you don't see my cursor, but you can see it here in the first plot on the left side. So early chronic patients using the rehabilitation gaming system RGS, so the red block, is significantly higher than late chronic. And this may mean that this critical window we were thinking that would close at 6 months is actually longer. It's actually closing later. But we need to have enough homogeneous data in order to capture this enhanced responsiveness to treatment at these early chronic stages. So with this data, we were validating the effectiveness of our system, and we were also exploring these patterns of recovery, proportionality, and temporal structure. But we observed that, again, the retention of skills that were gained during the therapy were quite low. Like patients were showing deterioration or were not showing further gains after therapy discharge. And some of them were showing this rehabilitation gain, this deterioration, right? So we wanted to address this specific issue, because why are we going to put so much effort in enhancing rehabilitation if later they are just going to lose it, right? So we thought that one reason why this may happen is that just after hospital discharge, patients present compensatory behaviors. Through motor adaptation and optimization, decision-making about which actions to trigger to satisfy certain goals, we see that these patients tend to overcompensate in 2 different ways. Either they modify actions when using their affected limb, for instance, exaggerating the trunk flexion forward or rotating the shoulder. So they modify their current repertoire of movements when using their affected arm, or they just completely or partially substitute these movements, right? How? As I was saying before, by using the non-affected arm. So they select to use the other arm, the one non-affected or less affected, in order to perform the same action, a reaching task, for instance. And this leads to a model that has been investigated by the USC, University of Southern California, that proposes the principle of use it or lose it. So if you don't use it, you will lose this skill. If we ground on this principle of how the brain works, then we can see that by compensating for or overcompensating by using the non-affected arm, patients are not exposed to learning to error, right? So there's no learning. And then this means that in the future, the outcome of selecting that action is gonna just deteriorate because of lack of exposure. So this puts the patient into this vicious cycle of recovery in which just deterioration is going to take place, or it predicts the further deterioration, right? So non-use leads to this deterioration. And this is what is called learn non-use. This model, this cycle, or model of recovery grounds on the simple idea that action selection and function or performance reinforce each other in both directions, right? So this means that error is leading to different probabilities in the future selection of the action we just performed, and the error is also driving learning. So it's like a dual path, right? There are some approaches for trying to reverse this cycle, convert it into a virtuous cycle of recovery. One of the most known one is constraint-induced movement therapy. So it just forces the use of the affected arm. So instead of allowing the patient to choose freely which arm to use, this type of therapy would place a meat on the non-affected arm of the patient in a way that the non-affected arm is not functional, and the patient has to just use the affected arm around 80% of the wake hours. So it's quite intense, and it requires supervision. It's not suitable for patients that do not have enough distal function or proximal function, and is not recommended for patients who have depression or are prone to it. So I think it's like, if I remember well, about only 7% of stroke patients with upper limb hemiparesis are suitable candidates for this therapy, and the rest really are not not administered with this, or not. They are not recommended with this, right? So so our question was, so how can we give an alternative to those patients that are not suitable for constraint-induced movement therapy? And we thought that instead of forcing, we can reinforce the use of the affected arm by just manipulating the feedback error, right? So to do that, we implemented a method in virtual reality in which we cheat the patient by showing through visual feedback that the movement of the arm, when it's the affected arm used or selected, the movement looks better than it actually is. How we do this? So we amplify the movement both in terms of range or extent and in terms of accuracy. And we do it in a way that is progressive within the trial and across trials. So we keep the patient unaware of this manipulation, the introduction of the manipulation. We tested this, and patients reported being unaware and just feeling that they were progressing very fast and learning very fast. Actually, we also tested it with healthy subjects or with non-neurological damage subjects, and they also reported being unaware of the manipulation. And it's because this manipulation is following the natural learning experience. So the patient is having feedback of getting better and better progressively. So also the implementation is very, very simple. It's kind of an attractor, and this was published in JNR. So in order to validate or to explore how this manipulation can have an effect on arm use, we designed an experiment that is based on 2 sessions. In the first session, patients went through this game in which they had to just place their hands on 2 home buttons, and then a target would appear at some specific angle, and they would just need to select which limb they would like to use in order to reach it. So they would freely select which limb to use. And we did not introduce any manipulation here, any amplification. But during the second session, next day, when the patient came back to the hospital, we divided the session in 3 phases: a baseline phase, an intervention phase, and a washout phase. And during the intervention phase, we faded in gradually this amplification, this visual amplification of the movement of the paretic limb, and then we faded it out during the first block of the washout. So what we saw is that during session 1, there was no effect on hand selection. During session 2, we observed that in the intervention phase, there was a shift, there was an increase in the probability of spontaneously selecting the affected arm. And you can see here on the top right that in the intervention phase, when compared to the baseline, that is the blue line, within subject comparison, the probability was significantly higher. But still, this probability of using the affected arm was significantly higher during the washout. That was a block in which there was no amplification at all. Also, we performed a sequential analysis of a hand selection, and we studied how experiencing success or failure when using the affected arm would increase or lower the probability of selecting again the paretic limb in the next trial. And here on the bottom right, you see that only when using the paretic limb, that is the yellow bars, you see that only when the patient used the paretic limb and failed to reach the target, now the probability of selecting it again in the next trial decreased significantly. So this was not, we didn't see this pattern when using the non-paretic limb, which made us think, or we could interpret from this, that patients are very, very sensitive to failure when using the affected arm only, right? So this type of manipulation may be quite effective if we want to also be able to regulate how much practice or how intense is the practice by allowing the patient to spontaneously use the one limb or the other. So they were doing an internal attribution to failure, apparently, when using the affected arm, and that's why they were choosing to not use it again after experiencing a failure. So, okay, after this, we wanted to really understand which are the long-term effects of this type of manipulation. And we started by modeling it. So we created a functional model of recovery that is based on a previous model from Swayhofer and colleagues from University of Southern California. It's a functional model that simulates a task in which a hand needs to be chosen in order to select, to perform a reaching movement towards a target. So at each trial, a target appears at a different location of the workspace, and then a decision has to be made, which is the best action to take, to move the right or the left hand, right? So the model is divided in 2 units. The motor unit, which it's implemented as if it would be a cortical area, because it implements 2 pools of direction-tuned cells, cosine truncated. So this has been supported by physiological studies. And also an action selection unit that is kind of an interactive race model conformed by 2 pools of neurons, one pool for each possible action. So in this case, action 1 would be selecting the right hand, and action 2 selecting the left hand, right? And these two pools would take a decision on which hand to use according to an activity threshold. So these two pools are activated by expected success from history of performance, and are inhibited by the expected cost associated with that action. And also, both pools are inhibiting each other. So it's a competing model, right? And after each trial, well, one hand or the other is selected to perform the action, and feedback on error, it's updating the motor unit, but also there is use-dependent learning mechanism. So both are combined in the same updating mechanism or learning mechanism that would relocate or change these direction tuned cells, right? So would change the direction, the sensitivity of each of these cells according to the executed direction. Then we have another mechanism for learning that is targeting the action selection unit, and is a reward-based learning mechanism. So we implement this model, and now we simulate a stroke patient. So how we do it? We train the model. We see that direction-tuned cells in the primary motor cortex reorganize in a way that the left hemisphere pool of neurons is satisfying movements that are more related to the right hand, right, and the reverse for the right hemisphere. So everything looks very consistent and it's stable. And at this point, we just kill certain neurons that are targeting directions in between 0 and 90 degrees. This is an arbitrary decision. So just after inducing this or simulating this stroke, we let the model run several trials in which we see that the patient develops, or the simulated patient develops, learn on use. So given the lack of coordination or accuracy and extent in this case of the movements when using the affected limb to reach targets appearing on the bottom right corner, the model learns to not select the paralytic limb when targets appear at that location, right? So now we simulate different rehabilitation therapies. So we expose these chronic stroke patients simulated to forced use. So repetitive trials of forcing the use of the affected arm. We expose him to no therapy at all, which is the bottom square you can see in this matrix. So in this matrix, you can see that the vertical axis corresponds to how probable is that we, by our therapy, we are forcing the affected arm. This constraint induced movement therapy simulated. And in the horizontal axis, we are showing the augmentation effect that I was mentioning before. We call it reinforced use. So we are manipulating the feedback error. The negative numbers indicate that we are, instead of reducing the error, helping or cheating in a helping the patient by reducing error, we are augmenting error. Okay. So we tested several combinations of these therapies, and in here I'm selecting 4 of them in which I want to show you further data. So on the top you see maximal forced use. On the bottom you see no therapy, and on the right side of the matrix you see 2 levels of reinforcement. One that is pure reinforcement on the bottom, and then a combination of reinforcement and forcing that is on the top. So what we see from the simulations is that these direction-tuned cells reorganize in all the cases in which we provide therapy, but not in the no intervention case. And both in the forced use and the reinforced use, mixed reinforcement and forced use, the results are quite promising. So it seems that we are able to restore the distribution of direction tuned cells to the state that, or a very similar state to the one that we saw before inducing the stroke. So reinforced use is an option that could be an alternative to forcing the use of the affected arm only as a therapy, but a mixed approach seems to be also a good strategy. So to test this, we went back to the hospital, and we now run a longitudinal clinical trial on stroke patients, 18. We divided them in two groups, an experimental group and a control group. And it was a nice study because we exposed them to this amplification of goal-oriented movements in virtual reality while performing reaching for, I think, 6 weeks. Yes, 6 weeks. And they were totally unaware of the manipulation. So it was triple blinded. So the patients were unaware of this manipulation through the visual feedback. Also, the therapists that were supervising the training were unaware of which patient was assigned to which group, and the evaluator also wasn't aware, so it was triple blinded. So we evaluated the motor function of the patients in Fugl-Meyer and other scales at baseline and also post-treatment, and at follow-up 12 weeks, so 6 weeks post-discharge. And these are chronic patients. So patients that could be engaged in this vicious cycle of non-using and therefore deterioration. So what we see is that, again, we see an effect on arm use. So those patients exposed to the amplification that we call experimental group, or EG, showed higher probability of using the affected arm. Then we again performed the same sequential analysis I mentioned in the last study. And in this case, we saw exactly the same. So patients were very sensitive to failure when using the affected limb, and this was having a direct effect on the probability of using the affected arm again in the next trial. So when experiencing failure in the next trial, they would decide with high probability of not using the affected arm. And then we looked at the effect on clinical scales, motor function, both in Fugl-Meyer and Cajal. Our primary outcome was Fugl-Meyer, and we observed an improvement after therapy in both groups, but only a significant improvement or superior improvement in the experimental group at follow-up, 12 weeks post-treatment. So we don't really understand, 6 weeks post-treatment in this case, so 12 weeks since recruitment. And we don't understand exactly why this happened. It could be that through the exposure to this enhanced success and this enhanced arm use or spontaneous selection of the paretic arm, the patients, even when leaving the hospital or the treatment, keep on with higher confidence using the affected arm for performing other activities. And this means that the therapy continues even when the patient stops therapy at the hospital, right? It continues spontaneously occurring through performing activities of daily living. But this is what we are testing now, because actually we could not test that. We need to now provide patients with a wearable and with a system that is 24/7 capturing arm use in order to better understand how these effects are retained, arm use effects, and how also they reinforce function enhancement, right? Like recovery of function. So we have done a pilot study on this in 2015. It was like a very early approach, only with 4 patients. The results were very promising. But now we are launching a European trial in 3 different countries, Sweden, France, and Spain, in which we are recruiting 100 patients, and we are going to follow them with smart watches for up to 1 year. So we want to further explore this model of mutual reinforcement in between arm use and recovery of function, because we believe that if we are able to prove that this model is right, then you can imagine, as you saw before, this model is bistable because function and use reinforce each other in both directions. It's a cycle. So therefore, it's kind of an attractor that is bistable. Either the patients are in the vicious cycle or they are in the virtuous cycle. If we are able to recognize or identify by behavioral data that patients are already into a virtuous cycle of recovery, then these patients do not need further therapy. They should be discharged from the hospital because they are going to recover spontaneously because they are using enough the arms spontaneously in order to learn from eating, showering, or dressing up, right? But on the other way around, so those patients that are engaged into the vicious cycle should not be discharged because as soon as they are discharged, they're going to stop using their affected arm progressively, they're going to lose function, and we're going to face rehabilitation in vain, which is a waste. So we want to understand better how to detect the threshold at which patients get into the virtuous or the vicious cycle, and to identify, if we would be able to identify whether they are in one or in the other state, then we can provide AI-based and evidence-based discharge schedules, recommendations, right, for clinicians, which would save a lot of money and improve patients' quality of life, right, and outcomes, clinical outcomes in general. So that's very promising, but one concern we have is that if we diminish error, if we amplify movement in a way that we show that the movement is better than it is in reality, then that could be hampering learning, right? So if we look at literature, there are different approaches. Some authors support that the larger the error, the more the patient learns. And other approaches or other authors are supporting that it's not about size. It's about a memory of errors. It's about the frequency of exposure to certain errors. And it may be that those errors that we identify or that repeat more often are those errors from which we learn more. If this is actually the case, then through our method of amplification in virtual reality, even though we are diminishing the error, we would not be hampering learning in patients, at least through motor adaptation. So we now perform a study, an experimental study with, in this case, is healthy subjects, in which, again, we apply the same mechanism described before, a very simple attractor mechanism for diminishing the error, both in terms of extent and in terms of accuracy. And on top of that, we apply perturbation.
Hi, Belen, you are muted suddenly. You seem to be muted. I can see that you are muted. Your mic is off. Can't hear you. Hello, Sundari. What happened?
I'm not sure, sir. She has muted herself, I think. There's no problem from our side.
Did you press the mute button by mistake or something?
Okay, now
Yeah,
you hear
no,
me?
yeah.
Okay, yeah, my
Okay.
earphones just ran out of battery.
Oh, okay.
So I share
Sorry
again
about
this.
that.
Yeah.
Okay, just a second. You see my screen?
No,
Okay.
no, I think you stopped sharing this.
Okay. Sorry. Okay, we are back into it now. Yes. So now you see the screen?
No.
Yeah, okay.
Yeah, now it's coming. Yeah.
Okay, great. So yes, okay. So we now apply this mechanism for the amplification of goal-oriented movements, but in two directions. Either we use it for diminishing error, and this is a condition we call M+, or we use it for augmenting error. That is a condition we call M-. So M+ would be a positive reinforcement, and M- would be a negative reinforcement because we are showing that the error is larger than it actually is. And we expect that by incorporating these two conditions, we would be able to change the distribution of visual error to which we are exposing the subject. So both conditions would show a distribution of error that is centered at 0, but in the M- condition, we should be able to see that this manipulation is increasing the variability of the error magnitudes that the patients or the, well, in this case, the subjects are exposed to. So if it would be the case that we learn more from those errors that repeat more often, then subjects should learn more from the M+ condition, because it's the condition in which we have high frequency errors that are close to 0. And in the case of the M- condition, we have low frequency errors that are close to 0 and low frequency errors also that are far from 0, right? So if it's about the frequency of errors and we learn more from those that repeat more often, then in the M+ condition, we should see an enhanced learning response. Okay, so we designed this study dividing it in 3 blocks. So all subjects are exposed to the 3 conditions, M+, then neutral mapping, that is NM. We don't apply any manipulation here, any visuomotor manipulation. And then the third phase, that is the M-, negative reinforcement, increased or larger errors and widely distributed, right, like increased variability. And a second group, the same amount of subjects that would go through the 3 conditions, but in the reversed order. We extract measurements of motor adaptation according to literature using the same methods and error sensitivity. So how much these subjects are responding or learning from error magnitudes. So as you can see, this is real data from all subjects, averaged across the different error magnitudes. And we can see that our mechanism is actually effective in manipulating the distribution of errors as we were predicting. So in the M-, they are high variable with low frequency of experiencing small errors, small magnitude errors, and in the positive mapping condition, you see high frequency of small magnitude errors, right? So now what we see, and this plot, I have to tell you, it was so neat that when we got it, we thought it was an artifact in our MATLAB script because it was really like symmetric, like it looks so nice. And what you can see here is that when exposed to M+, so reinforced low variable errors centered at 0 with high frequency of small errors, subjects learn more from small errors. And they learn more from small errors than the other two conditions, right? And what was even more shocking is that, I mean, at this point we thought, it looks so neat also that it may be an artifact of our own manipulation, right? So we were not sure about whether this method was valid. And we thought about looking at the neutral mapping condition only, because this was the cleanest set of trials we had, since here there was no manipulation at all. If there is actually a memory of errors that is biasing how much we learn from certain errors, then we should still be able to see the effect in the neutral mapping condition, right? And this is exactly what we see here. So we divided the data set in the 2 groups we had. So as I said before, like half of the subjects were exposed to the negative mapping and then to the neutral mapping. And the other half were exposed to the positive mapping and then to the neutral mapping, right? So when we look at the neutral mapping dividing both groups, we see that when exposed to no manipulation at all, those that just experienced highly frequent small errors were still learning more from small errors. We're still adapting more when experiencing small errors, right? So this validates this idea that we don't learn necessarily more from larger magnitude errors, in proportion, of course, or from smaller. We learn more in proportion from those errors that occur more often. And it may make sense if you think that those errors that occur more often are those that may be attributed to our own performance and not to external facts or noise, right? So in Erster 2015, who proposes first this idea of there is a memory of errors, he presents a model in which he says the model predicts that meta-learning vanishes when a small delay or gradual washout alters the history of errors. This proves that there is a memory of errors, right? And this is exactly what we show. This memory of errors vanishes very fast. In just 70 trials, we see, sorry, I go back, that in the last phase of the neutral mapping phase, this effect is vanished. So here in the first phase, we have 70 trials, and in the last phase, we have 70 trials. So just 70 trials is enough for just cleaning this buffer of sensory errors, right? That is biasing how much we adapt to a feedback. So maybe, I don't know if I have one more study to mention, but if you want, I don't know if it's too late, I can conclude or I can continue.
Go ahead, another 5 minutes, 10 minutes.
Okay, perfect. Yeah, so it's enough. So it's just that I wanted to mention now, as I said before, we are doing the effort of moving into other conditions too, trying to generalize those principles we learned about in the stroke domain to other domains. And we are looking also at the addiction case. So in this case, we are looking at alcohol users, but also cannabis users. And we found we targeted these patients because when we were exploring these motor learning aspects, we read about cerebellum, of course, which is the target structure, and it's interesting that it's the structure that is containing the highest density in endocannabinoids. And we thought that it could make sense that patients exposed to or users exposed to cannabis frequently would have some functional alterations in cerebellum. So actually, there is a recent paper suggesting that complex spikes in cerebellum are encoding direction error. So this is critical for adaptation, but also for forming memories of error memories, right? The mechanism we were discussing before. So neuroadaptation may be modulating error sensitivity through direction-tuned cells that have been recently also discovered in cerebellum at the population level. So when we look at CB1 receptors, as I said before, there is very high density of these receptors in cerebellum. However, these patients, cannabis users, are not diagnosed with visible structural damage. So there is no visible structural damage in cerebellum. However, we have done a review and on the conditions associated to cannabis use, and we see that there is quite a lot of evidence of motor impairments associated to it, right? We also see that the number of spikelets are reduced significantly when we have alterations in the endocannabinoid system in cerebellum, and also the ability to acquire conditioned responses is also affected. So altogether, this study suggests that motor coordination and adaptation could be affected by the chronic use of cannabinoids. And this is what we test here with 16 chronic cannabis users with 24 hours abstinence and with positive THC urine drug test, and we compare it to 13 age-matched controls. We expose them to an adaptation, motor adaptation or visuomotor adaptation paradigm that is quite known in the literature, but it's just to summarize it, it's just introducing a perturbation that the subjects need to compensate for. So during a baseline, they learn to just perform a reaching task towards a target, as you can see here, that a target that can appear at different directions. And then we introduce a second phase in which suddenly we impose a perturbation. You see now that the cursor didn't manage to go to the target. So they try again, and you can see that the cursor is going exactly to the target that is the neighbor target counterclockwise. So at this point, we stop the experiment and we say to the user, to the subject, we just cheated you. We are imposing a 45 degrees perturbation exactly, and we are gonna keep it. So for you to perform better and to go to the target, we will tell you a trick. You have to now aim at the target that is neighboring the target you actually want to reach, but clockwise, okay? So the right target, let's say. So just after that, you see how subjects in the next trial, they perform great. So they can compensate for it, and they compensate for it in a way that is explicit by using a strategy, a rule. But even though they are using a strategy and their performance is perfect, it doesn't mean that at the low level, cerebellum stops learning. You can see how even after using this strategy, their performance starts accumulating an error because the cerebellum keeps on learning from the mismatched feedback, right? So this is what you see here in this plot. Just after a big error of minus 40 something degrees, again, subjects, we explain the strategy to the subjects and they go back to baseline, and now you see how an error accumulates. And in the case of the cannabis, chronic cannabis users, the green line, we can see a significantly lower adaptation rate compared to controls. Interestingly, when we do not provide online feedback and we only provide endpoint feedback, all subjects, controls, and cannabis users, chronic cannabis users, are able to perform exactly the same, right? So they are able to follow the task without problems. So apparently this suggests that the chronic cannabis users have an altered adaptation performance. It seems that learning rates slow down, and this may be related to some altered functionality in cerebellum. So in this case, these patients are underdiagnosed because even though they are not presenting structural damage in cerebellum, we are able to see functional alterations. So this is just an example of how we are now moving into other domains and we are trying to use visuomotor adaptation paradigms also for diagnostics and evaluation. So just to conclude, we have seen that virtual reality allows for the implementation of principle-based treatments and evaluations, and even reveal we can reveal through our data that the critical window of recovery extends beyond 6 months. That is what literature usually is suggesting. Also, we see that we can reduce error magnitudes through virtual reality, and this promotes our use immediately. But also, a model suggests that the long-term effects would be beneficial for function, for recovering function, and is based on this model of the virtuous cycle recovery model, in which function and arm use are reinforcing each other. So when we test it at the clinic, we see that actually we see long-term effects, and the benefits of being exposed to reduced errors or to a reinforced therapy seems pop up in the case of the experimental group when compared to the control group. And finally, we also do a study exploring how the augmentation of or the reduction of error could hamper learning, and we see that it's not the case because we don't learn more from big errors, we learn more from those errors that repeat more often. And in a last study, we are showing that chronic cannabis users seem to present an altered functionality when adapting, even though they do not present any structural damage. So this type of visuomotor manipulations are also useful for diagnostics. So just to conclude, finally, let me say that this is work done in collaboration with many institutions and with many people involved in our team. So I'm presenting this, but I'm not the only person on this, of course, because it's big work and it's in collaboration with hospitals from Barcelona, such as Bioengineering Hospital, but also in collaboration with companies and in the frame of different European projects. Thank you so much.
Thank you very much, Belen. It was a really wonderful talk. Really enjoyed it. I'm just wondering if anybody has any questions. You can ask the speaker.
Yeah. Hello, ma'am. This is Sundari. Thank you
Yes.
for it was really lovely. So I had one question. So in your talk, you mentioned about the 3 pillars, right? Improvement, retention, and generalization.
Yes.
Yeah, so in that, I had a small doubt, as in like, so even though the therapy that you're giving, it's for a certain specific task. So in that case, how do you ensure that it generalizes to other tasks that they might need in a day-to-day basis?
Yes. That's a great question. The easiest way to approach that problem is to just test patients in using clinical scales, such as the Fugl-Meyer or the Kahai scale, because these scales include items related to other tasks or other features of the motor system, such as even reflexes or range of movement or strength. But I agree with you that that's not enough. So what we want to do now, as I mentioned before, is we want to go to the patient's homes, we want to bring them with a smartwatch, and we want to capture function and arm use on daily basis while doing their activity of daily living. I think that's where the impact is. I don't believe on the model of rehabilitation in which patients go to the hospital, perform some tasks, and then go back home. I think that doesn't work. It's not a sustainable system, and it's not where we want to have an impact, right? I mean, we want patients to be able to brush their teeth. So that's where the therapy should happen. And that's where we should assess function. So I agree with you that it's not enough looking at the clinical scales. We have to go and see if now the patient can brush their teeth. And most of the times, there is a clinical scale called Bartel index that we often use, but it's asking the patient if the patient is able to brush their teeth or dress up. It's just a question, right? And many times patients do not answer accordingly to reality. Sometimes they may exaggerate or they are not very aware of the reality. So that's not enough. We need to really measure with objective data if this is transferring to their lives. Yeah.
Okay. Thank you. I just have one more question, if that's okay.
Yes.
You mentioned the vicious cycle and how reinforcement-induced movement therapy changes that with how you're trying to use force use to drive the error rather than error driving learning and outcome. So in that case, so the therapy that you administer is going to be for a much smaller time period than what they do than compared to their daily life. So in that case, wouldn't they switch back to that sort of a vicious cycle, where the error drives selection and then drives outcome?
Sorry, I didn't understand very well. Like, we are giving less, you said less error?
No, as in the therapy for a lesser time than when you compare the entire day of the patient, right? So that's what it is.
Yes. Yeah.
So in that case, wouldn't they switch back to that sort of a vicious cycle where the error drives action selection and outcome?
Okay. Okay, I think I understand. So you mean that once we release them and they face reality when there is no manipulation, no amplification, no cheating, now they will face a large error and they will immediately stop using the arm, right? This is
Not
what you mean.
immediately, but how do you prevent that? Is there a way you've thought of to prevent that?
Yes, totally. I agree with you. I think it's more complex than that, and this is what we want to look at it because many of these patients have enough strength and enough function to perform many actions, but they lack confidence to do it. But when you force them to do it, they are successful. In other cases, the cost is high. So they are able to do it, but they require a lot of effort to do it. So they actually have a healthy brain when they decide to not use the arm, right? I mean, this is a good optimization problem that they solve. But I agree with you that that's problematic, and that's why we are now also implementing in this watch that I mentioned, we are implementing a mobile app that is kind of coaching the patient. It's kind of reinforcing the patient 24/7, like even at home. It's just giving feedback to the patient to remember to use the arm and trying to give extra points when using more the arm. So it's trying to bring an extra value from external sources to the action that they have selected that is using the affected arm. So through that mechanism, I hope we will kind of compensate for this, what you're mentioning, but it's something we have to try, like something we are trying to pilot now, and it's a little bit early to say.
Actually, I have a question on the same issue of vicious and virtuous cycle. Because you are saying that it will be nice to know when this patient has entered the virtuous cycle, because then you can discharge the person from the hospital.
Yeah.
Is there some kind of an algorithm or some kind of simple test that you can give to the patient to determine this? That would be nice, right?
Yes, that would be good to try. We thought about this some years ago. Like, if you can manipulate the different parameters that influence the decision making of action selection, then you can detect the full, you can do a perfect regression, right? And identify the threshold and what these patients needs in order to cross it. The problem is that first, there are a lot of parameters that are very difficult to measure, like for instance, the cost of an action. And second is that many times you design these tasks in which there is this reaching involved, in which there is not a real physical object to reach, right? And the situation is very artificial. So I'm not sure how this also will transfer later to where it matters, that is the rest of the day at home.
Okay.
So I agree with you. If we want to understand and model exactly the threshold, that would be a way to go. But we would model it in a way that I'm not sure it would be robust enough for having an application. But scientifically, it would be very interesting. Yeah.
One question about your cannabis study. So
Yes.
you are saying that the cerebellum is involved, right? What about other parts of the brain, like basal ganglia, is likely to be involved? Have you thought about that?
Yes, we didn't think about that, but yeah, it's interesting. Now we are doing another study that is actually unpublished, and we are preparing the manuscript now with vestibular patients. And we see that they also present the same behavior as the cannabis users. So in this task, they show like some of these patients show no adaptation, no implicit motor adaptation, and others show an impaired motor adaptation compared, like a slower one, compared to the controls. And it's another example, I think, of an undiagnosed cerebellar damage that, since it's not structurally visible, it's not, right, it's not identified, but it's functionally visible. Like, yeah.
Okay, thank you. Any other questions? Anybody else? So do you also face this kind of silence in your group whenever you ask a question?
Yes. Yes, we do a game that is one brain, one question. So it's like our PI, Paul Verschure, he forces us to ask a question.
Yeah.
And it's funny. Yeah.
Yes. So then I think Gangadhar is also here. Hi, Gangadhar.
Sorry?
Gangadhar has also joined the meeting halfway through. Hi, how are you? Yeah, it was
So
excellent.
yeah, I joined at the end at the question and answers.
Yeah.
So thank you, Belen. It was wonderful that you could get connected and share your science.
Thank you.
Very nice
really
line
appreciate
of
your
work. I mean, it's very well presented. Yes, thanks a lot. So
Oh, he's
actually,
brilliant.
yeah, I can think of a lot of topics for collaboration, but maybe we'll get back to you on that.
Sure, that would be great.
And it's a very nice possibilities of collaboration.
Fantastic.
You know,
So
Barcelona is a good place to
it's a
stay,
good
right?
place, and yeah,
Yes.
yeah.
Not
Visit.
but yes.
And Madras
Okay,
too.
yeah. We should come sometime.
Yeah.
Once the COVID lifts off, we can travel to other
Then that's
places.
gonna be great.
Yeah.
We are saving for that.
Yes.
Fantastic.
Yes. Thank you very much, Belen. Thanks for coming and thanks for talking to us. Thank you. Bye.
Thank you. Bye bye. Have a nice day.
Bye. Bye.